Okay, well, welcome everyone to the second lecture of the morning. And it's a real pleasure to be out here in Kona. The weather's been beautiful so far. I think it should be quite a great week. This next topic is acute bowel disease. And it's a topic of great interest of mine over the years because I think bowel disease imaging is quite challenging. And I hope to share with you some of the heuristics or shortcuts that we've been using at UCSF to help us make diagnoses more quickly and more confidently. So these are techniques that we've been playing with and using for the last many years. Just a few disclosures. In particular, I'd like to talk about small bowel obstruction. It's such a common entity and takes up 20% of our surgical admissions. In particular, I'd like to point out that bowel ischemia is the #1 cause of litigation against physicians, including radiologists, in the acute abdominal setting. So this is a topic that's very familiar to all of us, but I think we can always get better at evaluating bowel obstruction and in particular bowel ischemia. So I'd like to share with you some of our findings and some of the findings in the literature as well. Whenever we evaluate a patient with possible bowel disease, these are the 3 points I'd like to address. First of all, how sick does the bowel look? And there are certain CT findings in particular that we can use to evaluate the severity of disease. Second point, we'll look at the transition point if we have a bowel obstruction. And only after we find a transition point can we really have confidence in determining what the etiology of the bowel disease is. I think the most important point is to look for the severity. What do we mean by the severity of bowel disease? Is it a simple bowel obstruction where there's no ischemia, or is there a strangulation and ischemia, perforation, or a closed loop of the bowel obstruction? I think there's lots of ways to look at this, and the most striking feature that we see at imaging, whether it's CT or MR or other imaging methods, is pneumatosis intestinalis. When I was a resident, I was taught that this was the most important finding to look for. But I disagree with that. After quite some time looking at these images, we can certainly see non-dependent gas in segments of bowel, either on CT or on MRI. But it's often difficult to tell whether it's truly pneumatosis intestinalis or not. And also there were other papers and other findings where pneumatosis is not well correlated with disease. So for example, here's a case. This is a patient who received oral contrast. We can see non-dependent gas, gas below the level of the contrast. Normally gas should float up to the non-dependent or to the anterior portion of the bowel. But how do we look for pneumatosis? And if we were really concerned, we would flip over to lung windows. So here's lung windows. And now we can see in numerous segments of bowel that the mucosa has been lifted off by gas that's dissecting below the level of the mucosa in many segments of bowel. So we can confirm that there is some gas in this one segment of bowel, but there are numerous other segments that are even more severely involved by pneumatosis. Also, by using lung windows, we can see things such as gas in a portal vein tributary, a small mesenteric vein. And we can also look elsewhere in the liver, such as gas within the portal vein itself. We can look for perfusion abnormalities in the liver if there is gas that has migrated up into the liver. And it used to be, there was a lore saying, hey, if the gas is more central, it's more likely to be pneumobilia. If the gas is more peripheral, then it's more likely to be portovenous gas from ischemic bowel. I think with the modern multi-detector CT scanners, we can see the contrast in the portal vein quite well. We can actually see the location of the gas, whether it's in the bile ducts or whether it's in the portal vein fairly well. And we can look for perfusion abnormalities that were maybe not so obvious on prior imaging or the older CT scanners. So why don't I like pneumatosis intestinalis? There were several studies, this is one of them, that showed that, in pneumatosis intestinalis related ischemic disease, there really is not a great correlation with the finding of pneumatosis and the extent of ischemia. So some patients with pneumatosis will recover spontaneously, others will go on to have severe necrosis and die. So we really do need to look at other factors besides pneumatosis. There's another reason I don't like it is because we see many cases, if we look carefully, where there's pneumatosis and there's no symptoms at all of bowel disease. So these are patients in our hospital. Many transplant patients are on immunosuppressants. For some reason, they get pneumatosis cystoides intestinalis. This tends to be subserosal gas, and it may last for months. May get worse slowly over time, but the patients really don't have any symptoms. They don't have an elevated lactic acid. And the causes of benign pneumatosis cystoides intestinalis can be due to recent enteroscopy. It may be related to transplants, immunosuppression. We're not really sure why, or many, many other causes. So this is just a brief list of the kind of 2 pages worth of causes of pneumatosis cystoides. So rather than just looking for pneumatosis, we like to look at other features as well. This is a very instructive case. And I came across our film stack. And if we look through this case, I'll tell you there's no pneumatosis intestinalis at all. And this was read out by 2 very good radiologists as being just a case of a bowel obstruction. But if we look at these images, I'll tell you that there were several feet of dead small bowel. I'd like to point out there's no bowel wall thickening that we can see. But in retrospect, there is some very conclusive features in that we have a fair amount of fluid in the abdomen. And whenever we see fluid where we don't expect fluid, we need to look carefully. I'd like to point out these segments of bowel are ileum. We can see the normal enhancement, they're collapsed. And so we're looking at sort of the dilated segments of bowel. We should see an enhancing wall around the bowel, such as here, we can see enhancement of the wall. But these other segments of bowel, I do not see the wall. In fact, we cannot differentiate the free fluid in the abdomen from the bowel wall, from the fluid that's inside the bowel. And so the non-enhancement of the bowel wall, even in the absence of pneumatosis, even in the absence of bowel wall thickening, was a tip-off in this case. And so based on the patient's clinical presentation, not the radiology interpretation, this patient was brought to the operating room, and again, several feet of dead bowel were removed. So are these findings known? Well, here's another case, just an example. After we had seen that case, we started to see cases like this. This is an 83-year-old woman with abdominal pain. We can see normal enhancement of the jejunum in the left upper abdomen. But then just keep an eye on how brightly this bowel is enhancing. Down here, where we have the ileum, we begin to see free fluid. We begin to see poorly enhancing segments of bowel, and they're not dilated. There's no pneumatosis intestinalis, but the bowel wall seems to smudge into the background where there's edema in the mesenteric root and free fluid. And this patient we sent to the OR, she had many feet of dead ischemic ileum in her abdomen. And so even in the absence of bowel dilatation, no pneumatosis, we can make these diagnoses of bowel ischemia and infarction. So the clinical utility of CT, when we go to court as radiologists, the opposing attorney will say, oh, the sensitivity is 96%, specificity 93%, and there are many papers that quote very similar high accuracies. We need to bring ourselves up to speed to defend our interpretations. So what are some of these findings? This is a meta-analysis, a little old now, but the results still stand, looking at several features at imaging, in particular CT, for diagnosing ischemic small bowel obstruction. Which ones do you like? Which ones do you use in your practice? I'll tell you, I still don't really know what a serrated beak is, but that was a feature that was described in several papers. But what I do like is the poor bowel wall enhancement. I find this, although it's not sensitive, it's highly specific for ischemia. And what I've come to really realize is that mesenteric root engorgement, a hazy appearance of the blood vessels or enlargement of the veins, or mesenteric root haziness, kind of just fat stranding in the mesentery are quite helpful. We're surprised to find that wall thickening ascites were as well correlated as they were, maybe because these studies were a little bit older. But for example, let me show you this case. We can see there's some motion. The patient was in some extremis, so moving in the scan. We can see normal segments of non-dilated small bowel in the right abdomen. We can see enhancement of the bowel wall. In the contralateral abdomen, we can see dilated segments of bowel. In the mesentery, we have interleaving pockets of fluid that are kind of triangular in shape because they're between the leaves of the mesentery. We can see distinct fat stranding of the mesentery leading up to the dilated segments of bowel. And then we do not see bowel wall enhancement in several of these segments of bowel, so non-enhancement of the bowel wall. And in some segments, we do see some enhancement, but it's only very mild. This was proven at surgery to be a twisting of the bowel around the mesentery causing ischemia. So the balloons on a string sign, but really it's the mesenteric fluid, fat stranding, and non-enhancement of the bowel wall that allowed us to make this diagnosis without the finding of pneumatosis intestinalis. I'd also like to point out, misty mesentery, fat stranding of the mesentery is common. It's more common as we get older. There's been a couple papers written about this, but it really has no clinical importance unless there is some other disease that we see elsewhere. So unless we see dilated bowel, we're not going to really worry about the misty mesentery. Unless we see lymphadenopathy or other features of the mesentery that are abnormal, we're not going to worry about a little bit of fat stranding of the mesentery. So we will look at the mesentery, we'll look then at the bowel and other organs, but a fat stranding of the mesentery in and of itself is not something that we worry too much about in terms of ischemic disease of the bowel. I'd like to point out another myth. This is actually missed by three very good radiologists. And the question was, the patient was septic. Was there a bowel perforation? What do you think? The interpretation in this case was there's a very dilated colon, but it's maybe at risk of perforation, but it's not perforated. Unfortunately, this was a perforation, and we can see the colon in retrospect in the colonic gutter. And what we have here is peritoneal enhancement from a massive rupture with excessive free fluid and free air, where the bowel is actually floating in a soup of the abdomen. And there's quite a lot of fluid. So the patient eventually wasn't doing that badly, but within several hours afterwards started to crash and did not survive. I think it's actually harder to diagnose a massive perforation than it is to diagnose a small perforation where you see small amounts of gas along the anterior portion of the abdomen. A massive perforation with the peritoneal enhancement can simulate a large colon. But what we also noticed was there's a single fluid level that went from the symphysis pubis all the way up to a diaphragm. And we've never seen that. We've subsequently seen that in many other cases, but those are all with massive air and fluid levels in the abdomen, in particular the peritoneal dialysis patients, where it's not necessarily a concern. But if we do see a continuous air and fluid level that goes all the way from one end of the abdomen to the other, we have to look carefully. And the other feature is to look for the floating segments of bowel that pooch up and do not form kind of round interfaces with other segments of bowel. Let's move on. When we look for patients with possible ischemic bowel, acute abdominal pain, blood in the stool, we can look at the blood vessels as well. In this case, here's the aorta, and here's the superior mesenteric artery. We have a clear-cut embolus. How do we know it's an embolus? It has a tram track appearance. There's some contrast going on either side. We have a cutoff sign, meniscus sign, and there's a clear-cut filling defect. It's not a thrombus that formed along the wall of the blood vessel. It's an embolus. We can also look at the end organ, in this case the bowel, and we can see that there is non-enhancement of these segments of dilated bowel. The other segments of bowel that are collapsed have normal enhancement. The dilated bowel have no enhancement. And actually, this patient underwent an embolectomy. And even though the bowel was ischemic, the bowel became pink again and was able to save the bowel. This patient was not so lucky. It's a patient with an aortic dissection. We can see the true lumen. The false lumen is quite big. And the true lumen then compresses. We do not see the origin very well of the celiac artery or the superior mesenteric artery. And of course, we also do not see the bowel wall enhancement of several segments of bowel. So this person required a bowel resection for the ischemic bowel. So far, what we've talked about is one type of ischemia. It's a pale ischemia, much like you have a pale ischemia of your leg. You have an embolus, acute obstruction of the blood flow, and that leg becomes absent of blood and painful. But there are other types of ischemia as well. We're all very familiar with transient ischemia with reperfusion, so-called shock bowel. So when we see pale ischemia, it's actually not uncommon to also see shock bowel adjacent to the segment that has non-enhancement. Why does that happen? This doesn't happen in the leg. It's because the bowel has a very rich arcade of other blood vessels that can open up and supply the ischemic segment of bowel. So the rich interconnecting arcades of blood vessels will allow some areas of bowel to recover, but those will look just like shock bowel when we see in a patient who has had hypotension. And the mucosa will become hyper-enhancing immediately adjacent to the segments of bowel that are hypo-enhancing or non-enhancing. And so transient ischemia, shock bowel often occurs adjacent to areas of pale ischemia. So we all know this appearance of bowel where we see extreme hyperenhancement of the mucosa. That means the patient at some point in the recent past, in the last several days, dropped the blood pressure very low and needed fluid resuscitation, and then the mucosa becomes hyperemic. Here's another example, patient with a cardiac cath. We can see some retained contrast in the kidneys, and we can see the shock bowel appearance, the hyperenhancement of the mucosa, really finely etched, bright plica conventis of the small bowel. Another type of ischemia that we can see is a venous impairment. So for example, in this case, we can see a branch of the supramesenteric vein that was occluded and expanded. In this case, we have good arterial supply, and so we can see a little bit of enhancement of the bowel wall. And this is very similar to venous impairment of other organs, the brain or the kidneys. But what we also see is we see marked wall thickening of the bowel. Why is that? It's because we have high pressure arterial flow still trying to get into the bowel, but we've obstructed the outflow of blood into the vein. And so these segments of bowel tend to become very thick-walled very quickly after this event happens. In this case, the clot went all the way up to the portal vein, and these segments of bowel were quite thick-walled. They almost look like an intussusception, but it's a case of venous occlusion that caused the bowel to balloon up, fill up with blood, and have stasis and become ischemic in this case. So just a cartoon, this is a summary. If we were to block an artery, what would happen is the bowel would become very devascularized quickly, would not necessarily become thick, but also what happens, so this would be non-enhancing. Sometimes we get recanalization via arcades from adjacent bowel, and we'll get enhancement of the mesenteric blood vessels first, or the mesenteric wall, and then we'll have the anti-mesenteric wall become kind of appearance of shock bowel. So have hyperenhancement adjacent to non-enhancement. Whereas for venous occlusions, we will block the outflow of blood, and the bowel wall become very, very thick very early on, might have a little bit of mild enhancement, but overall will look pretty dusky and thickened. Let's move on to the next point. We see we have sick bowel. It's either dilated or looks funny to us. If we see dilated bowel, we need to find a transition point. This is a point of debate. I've talked to many radiologists who I respect, and they'll say, why do I need to look at the transition point? It's a bowel obstruction. They'll go by the clinical findings alone. They'll take them to surgery based on clinical findings. But if we don't look for a transition point, how will you ever know what caused the bowel obstruction to begin with, or how would you ever know if there was a bowel obstruction to tell the surgeon about? We need to find that one point where the bowel becomes from a large caliber down to small caliber. And I think part of the reason people don't look for it is because it's hard. It's just very difficult to follow the bowel and find a transition point. So what I'd like to show you is a series of shortcuts. The phone might be ready. You might have a bunch of other studies where it's 5 o'clock. We're trying to get out of the room. We need some shortcuts to make a confident diagnosis. So let's find a transition point. These are the 4 heuristics I use. First of all, I like to give oral contrast for our patients with a bowel obstruction for this reason. We can see the contrast is going to fill up the proximal bowel, and there's quite a lot of contrast in dilated segments of bowel in this patient. Ignore the pelvic kidney. But as the contrast filters down towards the transition point, it will become more and more dilute. And we can see, this area of bowel is becoming more dilute. The contrast is hardly present in this segment. We can follow it downwards. Here's the most dark segment of bowel. And is it any surprise that right at this point, there's an area of hyperenhancement, a beak-like appearance of narrowing and a transition point past which the bowel is decompressed. So the look for the dilution of the contrast agent helps you very quickly find the transition point, even though there were many, many, many segments of dilated bowel, and it's quite helpful for that reason. So I tell you, this goes against the American College of Radiology recommendations, because there's a concern if you were to drink hypertonic contrast, you may vomit and aspirate. But I'll tell you, these patients are already vomiting, and if we use very dilute contrast agents, which are diluted down below the level of osmolality in the blood, most of our agents now are that way. 20 mils of contrast in a liter of water. And even if the patient were to drink 1 cup and then have emesis of 2 cups of contrast, still some of that contrast will go down and can help find that transition point. The natural extension of diminishing bowel contrast is the small bowel feces sign. There's sort of a built-in targeting of the transition point. So this patient received oral contrast. We can see some segments of poorly enhancing bowel, not much bowel contrast. And what happens as there is stasis of fluid within the bowel, what does the bowel wall do? It absorbs the fluid from the contents of the bowel. And so the fluid is being absorbed, and the contents of the small bowel begins to look like feces. And is it any surprise that we follow this down? It really looks like feces, that we get an area where we have a triangular transition point with hyperenhancement and some bowel wall thickening. This is the transition point. We also see some fluid in the immediate adjacent structures to the bowel. And we can be very, very confident that that is the location of the transition. So look for desiccated material, dry material in the bowel lumen, and that will lead us to the transition point. So small bowel feces sign, when I first heard about this, I was shocked, and it's been so helpful for us to find transition points and to be confident about things. We realized that it's not just helpful in CT, it's also helpful in MRI. Here's a T2-weighted sequence with single-shot images. You know that fluid is bright. So we can just look for segments of bowel that are becoming dark. And here's a segment of bowel that's not quite as bright as other segments of small bowel. We can follow this down to areas that are even less bright, and it follows it out the abdomen. Oh, there's a hernia causing a bowel obstruction in this case. So the small bowel feces sign is not exclusive to CT. It can also be adapted to other modalities as well. So the small bowel feces sign was initially described by Bill Mayo Smith, and was subsequently confirmed by many other papers. And it's more common in moderate and high-grade obstructions than it is in mild-grade obstructions, with a fairly good specificity for the transition point, around 82%. There have been some detractors saying that, for example, in this study of 1,000 patients, this person really had an axe to grind. He said, well, I can see small bowel feces in about 6% of my patients. But that's true, but if you look only at the patient with dilated bowel, where they're having symptoms of bowel obstruction, suddenly the specificity gets much, much higher. So we don't look for a small bowel feces sign if the bowel is collapsed. So many of us have slow transit, and at the ileum we'll have some desiccation of the bowel contents. But unless the patient's having bowel symptoms or the bowel looks sick, I wouldn't bother looking for small bowel feces. So our residents have started using the term fecalization of small bowel. I don't actually like that term. If we see dilated small bowel with other findings of obstruction, then we look for a small bowel feces sign to help us find the transition point. Otherwise, I don't find it to be a useful sign.